Right now, tens of millions of children and adults around the world take a small pill every morning just to be able to focus at school or at work. At the same time, the exact same chemical family, altered by only a handful of atoms, is currently devastating millions of other lives under a very different name, methamphetamine or meth. Same core molecule. Two almost unrecognizably opposite fates. One version is sitting in a medicine cabinet next to the orange juice. The other is at the center of one of the deadliest drug crises on the planet. To understand how one compound ended up living two such completely different lives, the story has to start in a laboratory in Berlin more than a century ago, with a chemical its own creator had absolutely no idea what to do with. In 1887, the Romanian chemist Lazar Edeleanu, working in a laboratory at the University of Berlin, successfully synthesized a compound he named phenylisopropylamine. He wrote it up, published his findings the way any chemist would, recorded the exact reaction that produced it, and then simply moved on to other research. No medical use was ever proposed. No one tested it on an animal, let alone a person. The compound sat quietly inside dry academic journals for more than 40 years, a molecule with no purpose, waiting for someone to stumble across a reason for it to exist. That someone turned out to be Gordon Alls, an American chemist working decades later on the opposite side of the world. In 1929, Alls was searching for a synthetic substitute for ephedrine, a plant-derived bronchodilator used to treat asthma attacks. At the time, nearly the entire global supply of ephedrine came from a specific Chinese herb, and the trade routes supplying it to Western pharmaceutical companies had grown unreliable and increasingly expensive. Alls resynthesized Edeleanu's 40-year-old compound in his own lab and then did something that no modern research ethics board would ever approve. He injected an experimental dose directly into himself to see what would happen. He recorded his own heart racing, his blood pressure climbing, his pupils dilating, and underneath all of that, a sweeping, unfamiliar sense of alertness and mental clarity that had nothing to do with treating asthma at all. It wasn't the drug he had set out to find. It was clearly something else entirely. Alls eventually settled on a simpler name for the compound, shortened from its full chemical description, alpha-methylphenethylamine, amphetamine. In 1932, the pharmaceutical company Smith, Kline and French turned that discovery into a consumer product almost overnight, launching the Benzedrine Inhaler, a small metal tube containing paper strips soaked in amphetamine, sold completely over the counter with no prescription required, marketed as nothing more exciting than a decongestant for stuffy noses and head colds. Anyone of any age could walk into a drugstore and buy one. It didn't take long for people to notice a side effect the packaging never mentioned: intense alertness, a rush of euphoria, and a total loss of appetite. Within a few years, people were cracking the metal tubes open, pulling out the drug-soaked strips inside, and either chewing on them directly or dissolving them into coffee or soda. A cheap, perfectly legal cold remedy had, almost by accident, become the first mass-market stimulant drug in modern history. But the single most consequential discovery about this compound came from an entirely unrelated medical accident, one that had nothing to do with colds, asthma, or getting high. In 1937, Dr. Charles Bradley was working at a children's residential facility in Rhode Island, treating young patients who suffered severe headaches after undergoing a diagnostic procedure called a pneumoencephalogram, an early and extremely painful method of imaging the brain. Bradley began giving the children Benzedrine simply to help ease those headaches. What he had not expected, and what no one at the time could have predicted, was that many of the children, particularly the ones struggling the most with behavioral problems and an inability to sit still or concentrate, became noticeably calmer, more focused, and dramatically more successful in their schoolwork almost immediately. Teachers at the facility started asking which children were receiving the arithmetic pills because the improvement in academic performance was that visible. It was the first documented clinical observation in medical history of a stimulant producing a paradoxical calming effect in hyperactive children, the exact founding observation that decades later would become the entire basis for treating what we now call ADHD with stimulant medication. Then came the Second World War, and amphetamine moved out of the pharmacy and directly onto the battlefield, at a scale the world had never seen before. Nazi Germany's military issued its soldiers millions of tablets of Pervitin, a form of methamphetamine nicknamed Panzerschokolade, or tank chocolate, allowing German troops to march and fight for days at a stretch, with little to no sleep. During the 1940 Blitzkrieg invasion of France, Britain's Royal Air Force handed out Benzedrine tablets to bomber crews to keep pilots alert through grueling overnight missions deep into enemy territory. American forces distributed their own stimulant rations across both the European and Pacific theaters. Imperial Japan manufactured methamphetamine domestically under the brand name Hiropon, distributing it widely to munitions factory workers to keep production lines running around the clock, and to kamikaze pilots in the hours before their final one-way flights. For the first time in human history, a psychoactive stimulant had become an official, government-issued tool of industrialized warfare. When the war finally ended, its chemical fallout did not end with it. In Japan, enormous stockpiles of leftover military-grade methamphetamine were dumped onto the open civilian market after 1945, often sold legally and cheaply in pharmacies to a population left exhausted and traumatized by the war. It triggered the first mass stimulant addiction crisis of the modern era, later remembered as the Hiropon epidemic, named after one of the most common brand names sold at the time. Estimates from the period suggest that hundreds of thousands, and by some accounts close to 2 million people, developed methamphetamine addiction within just a handful of years after the war ended. The crisis grew severe enough that the Japanese government passed the Stimulant Control Law in 1951, one of the first pieces of legislation anywhere in the world specifically targeting amphetamine-type drugs. Meanwhile, in the United States and much of the West, the 1950s and 1960s brought a very different kind of wave. Not an epidemic born from wartime surplus, but one built entirely on ordinary medical prescriptions. Amphetamines like Benzedrine and its close cousin Dexedrine were prescribed almost without restriction, as diet pills marketed heavily toward women, as treatments for mild depression, as general-purpose energy boosters handed out by so-called diet doctors for practically any complaint. Truck drivers relied on them to stay awake through overnight cross-country hauls. College students took them to cram through the night before exams. Competitive cyclists and other athletes used them to push through fatigue during competition. A compound that had started its life as a niche substitute for asthma medication had, within a few short decades, worked its way into nearly every corner of everyday American life. But that same widespread availability had a darkening underside. Dependence and abuse climbed steadily through the 1960s, giving rise to a subculture of so-called speed freaks who injected high doses of amphetamine directly into their bloodstream, chasing a far more intense and far more dangerous high than any pill could offer. In San Francisco's Haight-Ashbury district, at the peak of the countercultural movement, public health workers grew alarmed enough to launch blunt public warning campaigns with slogans like "Speed Kills," and in 1967, a physician named David Smith opened one of the country's first free clinics specifically to treat the wave of amphetamine addiction sweeping through the neighborhood. Lawmakers eventually responded in kind. The Drug Abuse Control Amendments of 1965 tightened restrictions first, and in 1970, the U.S. Congress passed the Comprehensive Drug Abuse Prevention and Control Act, which took full effect in 1971 and formally classified amphetamine as a Schedule II controlled substance, a formal government acknowledgement that the drug carried genuine medical value, but also a genuinely high potential for abuse. The era of amphetamine sold openly and without a prescription was over for good. Its medical career, though, was far from finished. Back in 1944, a Swiss chemist named Leandro Panizon, working at the pharmaceutical company Ciba, had synthesized a related stimulant compound called methylphenidate, reportedly naming it Ritalin after his wife Rita, who used the drug herself to improve her focus during tennis matches. In 1955, Ritalin received formal approval in the United States for treating hyperactivity in children, building directly on the exact clinical observation Dr. Bradley had documented nearly 2 decades earlier. Decades after that, a different amphetamine formulation with a far less glamorous history, an old diet drug called Obitrol, originally marketed for weight loss in the 1960s and 70s, was quietly reworked, rebranded, and relaunched in 1996 under a brand new name aimed squarely at the growing ADHD market, Adderall. From that point forward, both ADHD diagnoses and stimulant prescriptions climbed steadily, decade after decade, to the point that a nationwide Adderall shortage beginning in late 2022 left millions of patients across the country unable to reliably fill their own prescriptions for months at a time. And on a completely different branch of that very same chemical family tree, illegal methamphetamine never went away. If anything, it has only grown more dangerous. Modern methamphetamine, produced today largely in industrial-scale clandestine labs rather than small home operations, is purer, cheaper, and more widely available across the United States than at almost any point in the drug's history, and public health agencies have tracked a sharp, sustained rise in methamphetamine-related overdose deaths over the past decade, a crisis that continues to unfold in communities across the country largely out of the public spotlight compared to other drug epidemics. Put those two stories side by side, and the contrast becomes almost impossible to fully process. The very same basic molecular structure, first synthesized by a chemist who published a single paper and walked away, then rediscovered decades later by a man simply hunting for an asthma treatment, is at this exact moment doing two entirely opposite jobs on opposite ends of the same society. In one form, it lets tens of millions of people sit still, focus, and get through an ordinary school day or work day that would otherwise be genuinely out of reach for them. In another form, chemically almost identical, it is quietly destroying health, families and entire communities one dose at a time. Not every story in medical history ends with a clean, satisfying line drawn between the hero and the villain. Sometimes the most honest ending is simply this: the same molecule, discovered entirely by accident, can be turned into either a lifeline or a catastrophe, and which one it becomes depends entirely on how and by whom it ends up being used.